Good evening, everybody, and welcome to this 19th webinar organized by Oncquest Labs, New Delhi. Today's topic is myeloproliferative neoplasms. Now, this is part 2, in which we are going to cover three main entities: polycythemia vera, essential thrombocythemia, and primary myelofibrosis. The speaker today is Dr. Priya Murthy. Next one. Next one. Oncquest Lab is one of the major labs in the country, and this is accredited to NABL as well as to College of American Pathologists. That is, the CAP accreditation is also there. We have a national network and beyond in few neighboring countries also. We have a network of 43 laboratories, 350 collection centers, and 1,700 service associates. And we have a strong presence in South Asia, like we have a presence in countries like Nepal, Bangladesh, Burma, Kazakhstan, and other countries. Speaker today is Dr. Priya Murthy, who is MD from Ambedkar Medical College, Bangalore. And she is a consultant hematopathology at Oncquest Lab, Bangalore, and also Chief of Lab Services at Bangalore only. Her field of interest is hematology and bone marrow morphology. She has a special interest in immunophenotyping on bone marrow refined biopsies. She has conducted many workshops on bone marrow morphology and also participated in various workshops, and she has a few chapters to her credit which are written in various books, and she is associated with Karnataka chapter of IAPM also. See, today's topic of polycythemia vera, essential thrombocythemia, and primary myelofibrosis is actually the myeloproliferative neoplasms, which we all know are stem cell neoplasms. And these are different from other neoplasms of hematology, where leukemic cells are produced, like blast cells. Here we find there is effective proliferation with the production of or increased production of red cells, white cells, and the platelets. And each one leads to a separate entity. And whenever there is proliferation of fibroblasts, there is a formation or there is the disease, what we label as primary myelofibrosis. Now, in all these conditions, a driver mutation is essential. About 20 years back, when JAK2 mutation was discovered, it appeared that we have found a mutation which is diagnostic of polycythemia vera. So it appeared that all JAK2 positive cases will be polycythemia vera, but that was not to be. Now we know that JAK2 mutation can give rise to polycythemia vera in one individual. It can give rise to essential thrombocythemia in the second one, and it may give rise to primary myelofibrosis in the third one. Now, why is it so? Why this one mutation, and there could be three diseases depending upon individuals? And then in 2013-14, another driver mutation was discovered, and that was CALR. Now, WHO realized that we cannot rely on mutations as a cause, because one mutation can give rise to any of the three myeloproliferative neoplasms. And then the morphologic features of bone marrow aspirate and bone marrow biopsy were standardized. Once the standardization occurred, now we have the classification, and not only classification, the diagnosis of these myeloproliferative neoplasms is based on blood findings, and especially on the bone marrow aspirate and bone marrow biopsy findings, because these are now well standardized, along with the clinical features, the biochemical parameters, and the blood findings. All these combined, only one can give an integrated one diagnosis what the patient is suffering from. Now, how to differentiate one from the other when we know that there could be proliferation of erythroid series, myeloid series, as well as megakaryocytes in all the three conditions. Now, that is what is the most important, how to differentiate one from the other. So, Dr. Priya Murthy is today going to differentiate between these three entities and emphasize the significance and importance of bone marrow morphology in differentiating these three myeloproliferative neoplasms from each other. Over to you, Dr. Priya.
Good evening, everyone. Thank you for joining us for the second edition of Myeloproliferative Neoplasms. Today, I will be talking on the Philadelphia negative myeloproliferative neoplasms, that is, polycythemia vera, ET, and primary myelofibrosis. So let us start with the definition. Myeloproliferative neoplasms are clonal neoplasms, which are present in the bone marrow, and they harbor an MPN initiating somatic mutation. They're capable of indefinite cell renewal, and through various cell intrinsic and cell extrinsic effects undergo clonal expansion. So we know that myeloproliferative neoplasms comes under the category of chronic myeloid neoplasms, and they are divided into the classical ones and the non-classical ones. The classical ones are determined by the presence or absence of BCR-ABL. We have discussed CML, which is BCR-ABL positive, in the previous talk, and today we will be discussing on the BCR-ABL negative MPNs, which are PV, ET, and PMF. So a driver mutation is required for these Philadelphia negative MPNs, and there are three of them. The Janus 2 kinase gene, which undergoes mutation, is usually on chromosome 9p24, and they are of two types. Then this is a gain of function mutation. CALR mutation is a frame shift mutation which happens in the last exon of CALR gene, and the MPL mutation, which is another gain of function mutation. So the most common is the JAK2 V617F mutation, seen in about 95 to 97% of the cases of polycythemia vera. The rest of the cases of polycythemia vera will show a JAK2 exon 12 mutation. JAK2 mutation is also seen in a little more than half of the cases of ET, about half of the cases of primary myelofibrosis as well. The second most common driver mutation is the CALR mutation, seen in about 35 to 40% of ET cases and about 45 to 50% of primary myelofibrosis. MPL mutation is seen in a small population of ET and a small population of primary myelofibrosis. There are a few cases which are triple negative. That is, those do not carry any of the three driver mutations. These are the triple negative mutations. How then do we know that these are clonal? Because of the presence of other somatic mutations, and these could be IZH1 and 2, ASXL1 mutations, NPM1 mutations, and these can be present in these triple negative cases, as well as be present along with these JAK2, CALR, and MPL mutations. And when they are present along with them, they carry a poor prognosis and leads to a very aggressive disease. So this is a pictorial depiction of how the genetically predisposed hematopoietic stem cells, they, when undergoing a driver mutation, which is either BCR-ABL, gives rise to CML, or if they have any of the other two mutations, JAK2, MPL, or CALR, or these other somatic mutations, give rise to the other MPNs. So irrespective of the type of mutation, it is the JAK-STAT signaling pathway that is mainly affected. The JAK-STAT signaling pathway is normally essential in the normal hematopoiesis in the human body, also for controlling the immune response and the inflammatory response. So in these MPN patients, the JAK-STAT signaling pathway is activated, and there is a flush of following which there's a cascade of events leading to cytokine hyperactivation of this JAK-STAT signaling pathway, leading to the symptoms of the patient. And there is a genetic predisposition of these patients to progress on to a progressive stage of myelofibrosis or acute leukemia. So in all these conditions have specific clinical pathological criteria for diagnosis. They have some common features: increased number of one or more myeloid cells associated with hepatosplenomegaly because of the clonal marrow hyperplasia. Let us look at this case study of a 58-year-old male patient. He walks into the clinic with headache and a congested flushed conjunctiva, no other symptoms. He has no spleen, no liver, and basically no other symptoms. And when his blood works are done, his hemoglobin is raised, TLC is on the upper limit, DLC is within normal limits, platelets are also high. Now, what the clinician thinks of is this a case of MPN? Yes, it could be a case of ET, a PV, or a PMF. He doesn't know. So he orders for a JAK2 mutation. JAK2 is positive. He's still not sure whether it is an ET, a PV, or a PMF. So what is the next resort? A bone marrow aspirate and a bone marrow biopsy is done. Bone marrow aspirate is hypercellular, and the bone marrow biopsy is also hypercellular, and it shows a classical morphology, and we conclude that it is a case of polycythemia vera. So how does one mutation give rise to three different types of diseases? There are several hypotheses. One of them, most commonly accepted, is the gene dosage hypothesis, which has been described by Passamonti and Rumi in their article of Hematologica. And this is a pictorial depiction. And this is a correlation between the mutant allele burden with the clinical phenotype. So whenever there is a low dose of the mutant alleles, this is a clinical phenotype which is dominated by platelets, and this is seen in cases of ET. If there is an intermediate level of mutant allele burden, this is a case dominated by erythrocytosis, and this is seen in cases of PV. If the mutant allele burden is very high, it is a case dominated by leukocytosis, and this is seen in primary myelofibrosis. So what now? Now from this disease was discovered as far back as 1951 by William Damschek, and then he described it as myeloproliferative disorders. It was not known whether it was malignant or non-malignant. And until about 2008, there was extensive progress in the studying the etiology of this disease, because there were increased number of mature cells in the peripheral blood. And what they discovered during this period is presence of these driver mutations, BCR-ABL and the JAK2. That is when in 2008, the authors of the WHO Manual of Hematology and Oncology coined the word myeloproliferative neoplasm. And after that, several progress has been made. We know CALR and MIPIL also was discovered. So we know that this is myeloproliferative neoplasm is a clonal neoplasm. But Teferi et al. In their article of 2016 brought morphology to the forefront and described accurate reticular fibril grading, bone marrow with proper, with specific features, with appropriate clinical findings, and also presence of molecular markers to describe the entity of myeloproliferative neoplasm. So in 2016, what they did was brought morphology to the forefront and gave definite criteria for each of the disease with which we can identify each of them. So understanding the morphology of the marrow in each of these conditions is very essential to come to the right diagnosis, along with the clinical correlation as well as the establishing their clonal nature. Still, there are about 10 to 15, even after applying all these criteria, we still see about 10 to 15% of the cases are unclassifiable. So let's go to so in order to understand the morphology of the bone marrow, I will be describing specific characteristics of megakaryocytes in each of these diseases. And in order to understand this better, let us go through megakaryopoiesis, that is, development of the megakaryocyte. So it develops from megakaryoblast, which are about 10 to 15 microns in diameter. They have a rounded nucleus and a small amount of basophilic cytoplasm. Then the megakaryoblast develop into promegakaryocytes. These then slowly start developing lobulation. There is still some amount of basophilic cytoplasm. And as this cell matures into the granular megakaryocyte, which is more pinkish, having more granules, there is more lobulation in the nucleus. And finally, the mature megakaryocyte, which has abundant granular pink cytoplasm and a lobulated nucleus. So during the course of my talk, I will be describing normal megakaryocytes, dwarf megakaryocytes, giant, dysplastic, and megakaryocytes with bulbous and cloud-like nuclei. So normally megakaryocytes in an aspirate are discretely present amongst the hematopoietic cells of the marrow, and they are in various stages of maturation. In an aspirate, you come across mature megakaryocytes, immature megakaryocytes, and they're all discretely present throughout the aspirate. Likewise, in the bone marrow biopsy, you come across both mature and immature megakaryocytes in the central part of the marrow. If you see about 1 to 2 megakaryocytes in each marrow space, then you say the megakaryocytes are normal in number. And if they're in central, we say that they are normal in topography. Anything apart from this, we say it is an abnormality, and these abnormalities are seen in each of these cases, and that is what we are going to talk about today. So micromegakaryocytes are about the size of a promyelocyte. They have a non-lobated nucleus, which is immature, and a moderate amount of pinkish cytoplasm. Sometimes these have an eccentric nucleus. They also are occasionally bilobed and sometimes multilobated, and this is most commonly seen in MDS. If you come across micromegakaryocytes and these typical bilobed megakaryocytes, you have to look for other features and look out for MDS. Then we have giant megakaryocytes. These are like huge megakaryocytes, abundant pink granular cytoplasm, and a complex lobulated nucleus, which has multiple lobes. And these are present in essential thrombocythemia. We also come across dwarf megakaryocytes, which are 3 times the size of a micromegakaryocyte. They have a large immature nucleus, which is rounded, which do not have any lobulation, and have a small amount of mature cytoplasm. So these dwarf megakaryocytes are seen most commonly in chronic myeloid leukemia. The megakaryocytes, like I told you, they are present in the central part of the marrow, and about 1 to 2 megakaryocytes in each marrow space, discretely present, but they can also be present in clusters of more than 3 megakaryocytes. If they're present in loose clusters, there is some intervening hematopoietic cells in between the megakaryocytes, and if they are in dense clusters, they are so tightly attached to each other with opposed margins, and they can be seen in cases of primary myelofibrosis. So sometimes you can also come across megakaryocytes lining the dilated sinusoids as well as in the paratrabecular areas. These are all considered as abnormal topography for the megakaryocytes. Now, along with the morphology of megakaryocytes, we need to know the WHO has specified on accurate reticulin grading. So they have a grading system which includes 4 categories from MF0 to MF4. And MF0 shows scattered linear reticulin with no intersections or crossovers, and this is seen in the normal bone marrow. MF1 has a loose network of reticulin with many intersections, and this is seen especially in perivascular areas. MF2 is more diffuse, more cross-sections of the reticulin, and occasionally there are small bundles of them consistent with collagen or focal osteosclerosis. 3 is a diffuse and dense increase, extensive cross sections, and they're present in dense bundles associated with collagenization and usually always associated with osteosclerosis. So there are Mason's trichrome stain which can be done to identify these collagen bundles, and this is a case of osteomyelosclerosis which is seen in correlation with MF3. So there are several grading systems of reticulin that were used prior to this, and the most popular one is the Bodminster grading, which was introduced in 1971. It has a grading of grade 0 to grade 4, and grade 4 corresponds to MF3 of the WHO grading system. So this is also similar. Grade 4 has extensive intersections and collagenization. So now we know the molecular basis of all BCR-ABL negative myeloproliferative neoplasms are JAK2, CALR, and MPN. So polycythemia vera, almost all the cases are associated with JAK2 mutations. Essential thrombocythemia, you come across all the 3 of them, and so as in myelofibrosis. A small number of cases are triple negative in ET and in PMF, and these are associated with mutations in the genes ASXL1, EZH2, TET2, IDH1 and 2, SRSF2, and SF3 beta 1. These mutations are also known as the high-risk molecular mutations, and they can be present individually in these triple negative cases, as well as occur as the disease progresses. If the patient stops responding to therapy, then you have to look for these additional mutations, and these usually carry a poor prognosis. So having understood that these diseases are clonal, they have a specific morphology to each of them, they have the accurate reticulin grading is essential. Let us go on to understand the morphology of each of these entities. So essential thrombocythemia is a disorder of excessive megakaryocytic proliferation. Here the platelet count is increased 2 to 12 times the normal. Patients do not have any symptoms at the time of presentation, except during a routine checkup. They come with high platelet counts and then they are investigated. Sometimes they present with symptoms of vascular occlusion, thrombosis, or hemorrhage. Splanchnic thrombosis is one of the most common symptoms that is seen along with ET. So their white cell and red cell count are usually normal. Unless they have undergone severe bleeding, then they would be presenting with anemia. Otherwise, platelet counts are increased. So the criteria laid down by WHO is that platelet count should be greater than 450. Bone marrow biopsy should show a specific morphology, which I will be describing shortly. It should not meet the WHO criteria for the other MPNs, or it should also have the JAK2, CALR, or MPL mutation. A minor criteria is you should rule out a possibility of reactive thrombocytosis. So for diagnosis of ET, all 4 major criteria, or the first 3 major criteria and one of the minor criteria, is essential. Now in ET, you're seeing most of them present with JAK2 mutation, a good number with CALR mutation, and a small proportion with MPL mutation. There is a 10 to 12% of the cases which do not show any of these 3 mutations, and these are the triple negative cases. So other causes of clonal thrombocytosis you see also in polycythemia vera, chronic myeloid leukemia, myelodysplastic syndrome, especially those associated with 5q deletion. Reactive thrombocytosis is something that we need to rule out first in all cases of thrombocytosis. So we know that platelets are acute phase reactants. They increase in response to various stimuli, and they are also increase in systemic infections, inflammatory conditions, bleeding, and in tumors. And they are also associated with secretion of interleukins and other cytokines. They're seen in all chronic inflammatory conditions, in malignancies, in renal disorders, and very commonly in iron deficiency anemia as well. So in a case of ET, the peripheral blood picture do not show too many discrepancies, except that the platelet count is increased. You see a huge number of giant platelets which are hypogranular in nature. RBCs are normocytic, normochromic. Unless, of course, the patient has undergone some hemorrhage, you would find a microcytic hypochromic blood picture. TLC is normal. The bone marrow aspirate is essentially normocellular. This is something that you have to keep in mind. In all cases of ET, the bone marrow aspirate is normocellular. Why do I say normocellular? In an aspirate, you will find that there are a good number of fat spaces all across the aspirate. Erythroid series shows a normoplastic maturation. Myeloid series shows maturation up to neutrophils. There could be sometimes a slight increase in eosinophils. Iron stores are increased if you do an iron state. The major thing that you need to look out for is these giant megakaryocytes. Giant megakaryocytes, they are present in loose clusters. They show complex lobulation, and they show the characteristic, you see these complex lobulations, and they show a characteristic staghorn type of nuclei. This is the most important morphologic finding you see in cases of ET. Likewise, in the bone marrow, you see that this is essentially normocellular for the age-adjusted cellularity to be considered. Normocellular because there are a good number of fat spaces here. In the intervening spaces, you find these loose aggregates of giant megakaryocytes. Erythropoiesis and myelopoiesis are within normal limits. And usually there is no significant left shift. Very minor increase in reticulin is seen in the early cases. Suppose the reticulin is higher and you see, you have to reconsider the diagnosis of essential thrombocythemia. So you come across these large number of giant megakaryocytes in loose clusters, complex lobulations, and these are usually mostly present in the central part of the marrow. Occasionally, they may show a paratrabecular location as well. So this is with essential thrombocythemia. The next myeloproliferative neoplasm is polycythemia vera, where there is an uncontrolled proliferation of red blood cells beyond that which is normally responsible. So it is most commonly seen in men and in old age. They are present with a ruddy skin phase, intense itching. Sometimes these patients have this very characteristic aquatic pruritus. That is, when the patient gets into a shower, he develops intense itching because of the hot water. And this is a very characteristic sign. The patients come with almost like a braided skin because of intense itching. They also show brownish spots on the skin, arterial and thrombotic events. All these cases show a JAK2 mutation. Most of them a JAK2 V617F mutation, some of them the exon 12 mutation. They present with splenomegaly. And there are two phases, the overt polycythemic phase and the post-polycythemic myelofibrosis phase. This is a peripheral smear of a patient with polycythemia vera. Look at the smear compared to a normal smear. It is thicker and darker. This is because of the increased RBC count as well as the increased hemoglobin count. RBC is a normocytic normochromic with an occasional NRBC. Reticulocyte is normal. White cells are increased to about 20 to 50,000. There's a mild left shift, an occasional blast, or may not be a blast at all. Platelet counts are increased to 3.5 to 9 lakhs, and there are a good number of giant platelets as well. You frequently come across platelet clumps also in a smear. ESR is decreased and NAP score is increased. This is a picture of a bone marrow aspirate which shows nil iron stores because of the expanding erythrom. Now, the major criteria for polycythemia vera, the hemoglobin, which was earlier 18 grams, has been brought down to 16.5 grams in men and 16 grams in women. Or the hematocrit is about 49% in men and in 48% in women. Bone marrow shows a characteristic morphology, the details of which we will see shortly. They all have a JAK2 mutation, and the EPO levels or serum erythropoietin levels are usually subnormal. So a diagnosis of PV requires that all these three major criteria should be met, or the first two major criteria and the minor criteria should be met. So a polycythemia vera, the aspirate, is usually hypercellular and show panmyelosis. That is, there is erythroid hyperplasia, myeloid hyperplasia, as well as megakaryocytic hyperplasia. The bone marrow aspirate as well as biopsy are both hypercellular. And in a bone marrow aspirate, another clue you will find in the background, sometimes occasionally you come across platelet clumps. The characteristic morphology of these megakaryocytes in polycythemia vera are the varying sizes or pleomorphy of the megakaryocytes. There are small megakaryocytes and there are medium-sized megakaryocytes with some giant megakaryocytes. So this is a bone marrow biopsy in a 60-year-old male, age-adjusted cellularity, which is normocellular for the age. This is the same 60-year-old patient, another patient with polycythemia vera. See the cellularity of the bone marrow biopsy. It is showing 90 to 95% cellularity. You know the subcortical space should be hypocellular as the individual becomes older. You see in 40-year-old males or 40-year-old patients, you see the subcortical space which is hypocellular. But in cases of polycythemia vera, the subcortical spaces is also packed with cells. There is panmyelosis, trilinear hyperplasia, and different sizes of megakaryocytes. So this pleomorphy of the megakaryocytes, panmyelosis, and in the initial stages, there is some amount of fibrosis is a characteristic feature of polycythemia vera. In the initial cases of polycythemia vera, the hemoglobin level may not be so high. So patients may present with increased platelet count only. And these may be falsely diagnosed as a case of ET. But if you are able to put in the WHO criteria for each of these diseases, you will be able to conclude that this is probably a masked case of polycythemia vera and not ET. So most of the cases who present as ET progress or later will be concluded as a case of polycythemia vera. So the fibrosis, I said, is quite minimal in the initial stages of the disease. But if the fibrosis is more, then that patient will not do very well clinically. So as the disease progresses, the fibrosis also increases as well as extramedullary hematopoiesis resulting in splenomegaly. And when in the later part of the disease, the erythropoiesis is reduced. There is extensive fibrosis. There is myeloid proliferation as well as a megakaryocytic proliferation. And this may slowly, the blast count may also start increasing. And this is known as the post-polycythemic phase. So in these conditions where there is extensive fibrosis, the peripheral blood shows a leukoerythroblastic blood picture with teardrop red cells, nucleated RBCs, a slight left shift of the WBCs. And here you're seeing erythropoiesis is kind of diminished. Myelopoiesis is predominant with megakaryocytic proliferation. They sometimes they will be present in loose clusters, and varying shapes of these megakaryocytes will give you a clue that this is a case of polycythemia vera and not a case of primary myelofibrosis. If you do a reticulin grading, usually it is MF2 or MF3 on a grade as per the WHO grading system. So the next MPN we are going to talk about is primary myelofibrosis. This is associated with both megakaryocytic proliferation as well as a leukocytic proliferation. And as the disease progresses, there is progressive fibrosis and the patient may eventually land up with leukemia as well. So more common in middle-aged and elderly patients, and the classical symptom is fever, weight loss, and night sweats in these patients. There are 5 different stages of primary myelofibrosis: pre-fibrotic PMF, overt PMF, osteomyelosclerosis, accelerated phase, and blastic phase. The fibrosis that you see in myelofibrosis is a kind of reactive fibrosis. Normally, the fibroblasts secrete collagen in response to the cytokines liberated by the megakaryocytes, as well as the endothelial cells. But in these cases, the stromal cells interact with the neoplastic hemopoietic cells and deposit fibrin extensively. And as the disease progresses, the patient goes on to presenting with pancytopenia. So in the initial stages where there is pre-fibrotic PMF, when there is not much of a fibrosis, patient may present with leukocytosis as well as thrombocytosis and some amount of anemia. So the WHO criteria for pre-PMF is there is a megakaryocytic proliferation and atypia without reticulin fibrosis. If it is present, it is about grade 1. Doesn't have the other criteria for the other MPNs. It should have one of these 3 driver mutations. If these driver mutations are not there, the other somatic mutations should always be looked out for, and these are invariably present. So in a peripheral smear, you find normocytic normochromic RBCs. There will be some amount of anemia. Don't come across normoblasts or teardrop cells in a case of pre-PMF. But there will be leukocytosis with left shift and few blasts. Blasts are 2 to 3% in number. Platelet counts is increased. In an aspirate is hypercellular. You come across myeloid hyperplasia as well as megakaryocytic hyperplasia. Megakaryocytes are present in tight clusters. They are so tight that there is no intervening hemopoietic cells in between. And these megakaryocytes are severely dysplastic. This is the characteristic feature you come across in all primary myelofibrosis. The kind of morphology of these megakaryocytes is so classical that you can pick them up even in transformed cases. So these megakaryocytes, I told you, are sometimes paratrabecular in location, adjacent to bony trabeculae. They have these swollen, cloud-like nuclei, severely bizarre nuclei. There are some bare nuclei along with them. How bizarre these nuclei of megakaryocytes look. These are very classical of primary myelofibrosis. They are present in tight clusters with nil intervening hemopoietic stem cells. This is a case of primary pre-fibrotic PMF where the reticulin grading is almost nil. Then this disease progresses on to primary myelofibrosis fibrotic phase. Here the patient presents with features of a leukoerythroblastic blood picture in the peripheral smear. There are teardrop cells, left shift, and nucleated RBCs in the peripheral smear. WHO has given out the major criteria as megakaryocytic proliferation and atypia accompanied by reticulin of grade 2 or grade 3. It should not have other features of other MPNs. It should have a JAK2 CALR and MAPL mutation. The cellularity in a PMF fibrotic phase is slightly lesser than that of the pre-fibrotic phase. This is because of the extensive fibrosis. Erythropoiesis is almost diminished. You come across these tight clusters. There is fibrosis causing dilatation of the sinusoids. The megakaryocytes are seen adjacent to sinusoids. And you see the morphology of the megakaryocytes here. They're so tightly packed and so severely bizarre nuclei. This is a characteristic feature of primary myelofibrosis and should never be forgotten. Again, more pictures, and this is a megakaryocyte showing multinucleation. There are some bare nuclei, complex lobulation, bare nuclei. So this is seen in this fibrotic phase, lining the sinusoids and adjacent to the bony trabeculae. If you do a reticulin stain, this is usually MF grade 3, and the Masson's trichrome shows the collagen stain here, collagenization. So collagen fibrosis is intense here and associated with extramedullary hematopoiesis. This is seen in lymph node. So the osteoclasts, which originate from monocytes, are responsible for the bone remodeling and hence maintain the porosity of the bones. However, the osteoclasts which are derived from these mutated monocytes carrying one of these mutations have lost their capacity for bone resorption and bone remodeling. They've lost the capacity for osteolytic activity. Hence, they cause excessive deposition of bone on pre-existing bony trabeculae as well as new bone formation, resulting in markedly reduced marrow spaces and markedly thickened bony trabeculae. This is known as osteomyelosclerosis, and this is what primary myelofibrosis fibrotic phase progresses onto when untreated. So these are more pictures of osteomyelosclerosis where the bony trabeculae are intensely thickened, and this cluster of dysmegakaryopoiesis of megakaryocytes adjacent to the bony trabeculae in the fibrotic marrow gives you a clue that this is secondary osteomyelosclerosis secondary to primary myelofibrosis. So we have also semi-quantitative grading of osteomyelosclerosis from grade 0 to grade 3. Grade 0 corresponding to regular bony trabeculae. Grade 1 shows focal budding with hooks or spikes. Grade 2 is diffuse paratrabecular formation of new bone. And grade 3 with extensive interconnecting meshwork of new bone with overall effacement of marrow spaces. So normally it is considered that more than 50% of the marrow is reduced and it's showing extensive fibrosis, and it should be occupied by these bony trabeculae. Now this progresses on to the blastic phase, which is the blastic phase could be any of them. Could be any of the myeloid blast phase, or it could occasionally be lymphoid as well. This is a case in which there is M7 blastic phase. Accelerated phase when the blast count is less than 20%, and blastic phase when the blast count is more than 20%. And this is similar to that of the course of this disease is similar to that of acute leukemia. So the prognosis of primary myelofibrosis depends upon what stage the patient has presented with, whether he has presented in pre-fibrotic phase, fibrotic phase, or the other advanced accelerated phase. There are several scoring systems that have been established, including an online calculator. So wherein you put in the details of the patient, details like his hemoglobin levels, what genetic mutations he's carrying, presence of the high-risk molecular mutations, as well as the morphology of the bone marrow, and then you can assess how the patient is going to progress. So there is another category of myeloproliferative neoplasm, unclassifiable. This is an entity which describes cases have a definite clinical, laboratory, molecular, and morphologic features of an MPN, but fail to meet the definite criteria. You're not able to categorically say that this case belongs to a case of PV or a case of ET or a case of PMF because there is some overlap in the cases. This could be because of three reasons, either because it is very early in the disease, in a masked PV or an early PMF, or an advanced stage of myeloproliferative neoplasm where the disease is complicated by osteomyelosclerosis, or there is an accelerated or a blastic phase, or the myeloproliferative neoplasm has been masked by coexisting neoplastic or inflammatory disorder. All these conditions will cause confusion and will not enable you to categorize it into a specific entity. So this is placed in myeloproliferative neoplasm unclassified. So now we have understood the criteria for each of these diseases. We have understood that these are clonal, but this is not always the scenario when you get a case in your clinic. And also WHO has insisted that every case of leukocytosis or every case of thrombocytosis or every case which has a high hemoglobin cannot be placed under an MPN. You have to rule out familial causes of increase of these values. So I'm sharing with you two slides which I have picked up from Passamonte's article. And this is a very interesting flow chart. So suppose there is a patient, he has an MPN phenotype and he is having erythrocytosis. His hemoglobin is more than 16 grams. What you need to look for is whether he has thrombocytosis or leukocytosis. And you also have to rule out reactive causes of erythrocytosis. Reactive causes of erythrocytosis could be familial, could be because of living in high altitude conditions, because of pulmonary conditions, a COPD, for example, and even basically an anemia, where we can find erythrocytosis. All these cases of erythrocytosis have to be first ruled out before you actually think of acquiring P. vera. Then if the patient also has associated thrombocytosis or leukocytosis, again rule out reactive causes of thrombocytosis. All the cases of malignancy, iron deficiency anemia, any inflammatory causes, etc. Rule out reactive leukocytosis. Reactive leukocytosis as in inflammatory infective conditions, and also rule out CNL, CML, etc. Now, if you're able to exclude CML, test the patient for JAK2V617F as well as the exon 12 mutation. Do the serum EPO levels also. Serum EPO levels should ideally be done before the phlebotomy is done. So that is when you get the most accurate count. If the EPO level is low and JAK2 is negative, look at the bone marrow biopsy. If it shows a hypercellular marrow with trilineage hyperplasia and the pleomorphy of the megakaryocytes, it is a case of PV. Otherwise, rule out reactive causes. If the EPO level is normal or high and JAK2 is negative, look for alteration in the WBC or count. If there is a splenomegaly, then go ahead and do the bone marrow biopsy. Evaluate him for primary myelofibrosis. In all cases, don't conclude straight away an MPN, but rule out reactive causes. Suppose the EPO level is either high or low, but the JAK2 is positive, hemoglobin level is high, then look at, you can more or less say it is a polycythemia vera without even looking at the biopsy. But if you do a biopsy, you find the characteristic findings for a P vera. Suppose this patient is showing an MPN phenotype without erythrocytosis. MPN phenotype without erythrocytosis, again, look for reactive, rule out all the reactive conditions, familial thrombocytosis as well. Then test for BCR-ABL. If it is present, you are sure it's CML. If it is absent, look for one of these driver mutations. Usually in most of the labs now, they are doing it in a reflex manner. First, the JAK2 is tested. If it is negative, then the CALR is tested. If it is negative, then MPL is tested. So in a reflex manner, look for these driver mutations. If one of the driver mutation is present, associated with thrombocytosis, and the bone marrow biopsy corresponds here, this will be, to just as a recap, a normocellular marrow with giant megakaryocytes. Then you can conclude this is a case of ET. If no driver mutation is present, and you're still thinking of you've ruled out reactive causes, still thinking of an MPN, do a bone marrow biopsy and try to classify it into one of the categories, pre-PMF, PMF, or other myeloid malignancies. This could be all those triple negative cases which you have to evaluate for the high-risk molecular mutations. Now, if the driver mutation is present based on the platelet and leukocyte count, do a bone marrow biopsy, and cases of pre-fibrotic PMF as well as primary myelofibrosis can be detected, concluded upon. So with that, I come to the end of my talk, where it is emphasized that driver mutations are responsible for myeloproliferative neoplasms. Morphology of the bone marrow, examination, thorough examination, understanding is very important to conclude and place the disease in a specific category. Thank you so much. I would like to end my talk with the saying, challenges are what make life interesting, overcoming them is what makes life meaningful. I hope this goes with the diagnosis of our myeloproliferative neoplasms. Thank you, Dr. Tejindar Singh, sir. Thank you, Oncquest.
Thank you, Dr. Priya Murthy, for an excellent presentation and making a very difficult topic very, very simple, based on morphology, the reticulin assessment, the megakaryocyte morphology, and which cell lines are proliferating, whether erythroid only, whether myeloid, whether all the three. You made it very simple. Thank you so much. We have a few questions, and can we go through the questions, Dr. Priya?
Yes, sir.
Okay. There is marked thrombocytosis with increased granulocyte series. What will we give diagnosis as? Now, this is probably based on peripheral blood with thrombocytosis, increased granulocyte series.
Yes, so in these cases, definitely we have to take the patient history. History rule out any infective causes. Infective causes can give rise, inflammatory infective causes can give rise to thrombocytosis and increased granulocytic series. Check for the status of the spleen in these patients, interact with the clinician, get more history, and if necessary, if the patient is not having any infection, then probably you can go in for a bone marrow biopsy to assess the morphology and then place it under the right category.
Right. Then the next question is from Dr. Deepa. To report bone marrow aspirate, should we comment on cellularity always?
Yes, definitely. We need to give the clinician on the cellularity of the marrow. Sometimes it so happens that the aspirate will be, the marrow may be very cellular, but what aspirate you get, the cellularity may be low. This gives a clue to the clinician that there is associated fibrosis, and a bone marrow aspirate only is not as conclusive, but a bone marrow biopsy will be more diagnostic in these cases. So the quantity of fat present is always a clue to the clinician, and comment on cellularity is a must.
Okay. Dr. Deepa also asks, when do we say that the megakaryocytes are adequate in bone marrow aspirate?
So look at the aspirate, you find good number of fragments, good number of with a good number of fat spaces, and these megakaryocytes should be discretely present across the slide. So in each marrow fragment, if you're able to find one or two megakaryocytes, then we normally say that this megakaryocytes are adequate in number.
Then Dr. Deepa deviates from the topic and she goes on to acute leukemia. And she wants you to give us the IHC markers to differentiate AML from ALL.
Okay. So to call any condition as acute leukemia, first of all, we have to prove that they are immature in nature. The immature markers like CD34, TDT, CD117 for myeloid, these have to be done. And once these, with these markers are positive and you're sure that this is a case of acute leukemia, then look for the lineage. Whether it's a B cell, then you do all the B cell markers, CD20, PAX5, and if it's a T cell marker, then you have to do CD3 and CD5. And if it's a myeloid markers, the other myeloid markers like 13, 33, and all of those. You have to go in a stepwise manner. First of all, make sure the immaturity markers are present so that you're dealing with a case of acute leukemia and not that of a lymphoma.
Okay, then from markers, she goes on to cytochemistry in acute leukemias. And she says that she is not able to see PAS positivity in ALL. Can you share the technique which you are using in your lab?
I can definitely share the procedure with you, Dr. Deepa. If you can just drop me an email, I will respond to you with the procedure that we are following in our lab.
Okay, there is one more question. Will ET always have normal WBC count and no increase in granulopoiesis?
See, ET, that is the one of the way you distinguish ET. The cellularity of the marrow is normal, and the erythroid series and myeloid series are usually not so much affected. So unless there is an associated infection or there is acute bleeding which causes increased leukocytosis, I don't think so there should be an increased granulocyte count in a case of PP.
Right. I think this is the last question. Thank you very much, Dr. Priya, for sharing the PAS technology so that Deepa can benefit, and she thanks you for that. Thank you so much for a lovely presentation, and thank you, Amir, for organizing it. Thank you, Oncquest, for these webinars. Thank you all.
Thank you, sir. Thank you, Amir. And thank you, audience. Hope we connect on many more such webinars.
Okay.